Welcome to the session 5 of the General Pathology MCQ discussion. Let us have a question here. Most important chemical mediator of inflammation that induces fever is. So they are asking the chemical mediator that is responsible for the fever of the inflammatory process. Options: interferon gamma, bradykinin, interleukin 1, histamine. So all the chemical mediators of inflammation are given. Which is the correct choice responsible for your fever? Yes, correct choice is interleukin 1, actually interleukin 6 and tumor necrosis factor alpha. Three things are important for the onset of fever. Remember my friends, three important chemical mediators that causes fever are interleukin 1, interleukin 6, tumor necrosis factor alpha. So we have a choice here, interleukin 1. So that's why that is the answer. What does the interferon gamma does? Interferon gamma is the most potent chemoattractant for the macrophages that will not induce fever as such. Bradykinin. So remember the effect of bradykinin. It induces pain. It also causes the vasoconstriction. Histamine, most potent vasodilator. It increases the mucous secretions. So it's a vasodilator. Right, that's the point you have to remember. It is the interleukin 1 is the answer. Cytokines have all the following effect except. Easiest question here: autocrine, paracrine, endocrine, exocrine. Yes, except. What is autocrine? Autocrine, it acts on the own cells from which it is produced. So for example, interleukin 2 produced by T lymphocytes and it acts on the interleukin 2 itself. Paracrine, that is on the adjacent neighboring cells. For example, T lymphocyte secretes interferon gamma that acts on the macrophages. Macrophages secrete the interleukin 12 that acts on the T lymphocytes. That is paracrine action. Endocrine, that will go to the circulation and have a effect at the distant sites. So that also effect will be there, not exocrine. So answer should be the exocrine. Interleukin produced characteristically by T helper 1 that activates the macrophages is. That means which important cytokine is required for the activation of macrophage. We have so many interleukins here: interleukin 5, interleukin 1, interferon gamma, interleukin 10. So what is the correct choice? Remember my friends, interferon gamma is the most potent chemical mediator of inflammation. That is the must required for the activation of the macrophages, and that is secreted by the activated T lymphocytes. So the answer should be the interferon gamma. Yes, interleukin 5, interleukin 13, they are required for the activation of the eosinophils. Interleukin 1, interleukin 6, they are mainly the pyrogenic, that is producing the fever. Interleukin 10, remember it is having negative effect. It prevents, it inhibits the chemotaxis. So these are the effects you have to remember. All are true regarding nitric oxide except, also known as endothelium derived relaxing factor, potent vasodilator, half-life is very long, most potent microbicidal agent. The correct choice, the first choice you see here, it is also known as endothelium derived relaxing factor. Yes, that was the old name for the nitric oxide, potent vasodilator. Remember, endothelium derived relaxing factor, that because it relaxes, so that's the most potent vasodilator. So both are correct. Half-life is very long. No, most of the chemical mediators are very short acting. Nitric oxide acts only for around 8 seconds, not more than that. So most of the chemical mediators of inflammation, you should remember, they are having very short half-life in terms of seconds or few minutes. Most potent microbicidal agent. Remember, it is the only chemical mediator of inflammation which also act as a microbicidal. So it's the most potent microbicidal agent. That's true. Increased capillary permeability is caused by all the following except. So here again you have to remember the various actions of the various chemical mediators of inflammation. Increased capillary permeability, that means vasodilatation, is caused by all the following except: bradykinin, 5-hydroxytryptamine, prostaglandin, histamine. So which is not a vasodilator? Indirectly they are asking which is not a vasodilator. So which is the one responsible for the vasoconstriction? Remember 5-hydroxytryptamine and is nothing but serotonin. Right? So serotonin and histamine are having almost the same action. They are very potent vasodilators. Yes, we have a prostaglandins. Most of the arachidonic acid metabolites are the vasodilators except thromboxane A2. Thromboxane A2 is the vasoconstrictor. So prostaglandins are again vasodilators. So the option we have left is now the bradykinin. So the bradykinin not only induces the pain at the site of injection, the pain of inflammation most commonly caused by the bradykinin, it also causes the vasoconstriction. That's the point you have to remember. The epithelioid cell and multinucleated giant cells of granulomatous inflammations are derived from. So indirectly they are asking what is the cell of origin of these epithelioid cells. Options: basophils, eosinophils, CD4 lymphocytes, monocytes. So try to revise the granulomatous inflammation. From here these epithelioid cells have been derived from. So answer is monocytes. Yes, the correct answer is monocytes. The T lymphocytes will keep on secreting various interferons. Mainly it's IFN, interferon gamma. That's the one which will attract these monocytes. Circulating monocytes will be attracted and they will be sent to the tissues. Once the macrophages, these monocytes enter into the tissues, we call them as epithelioid cell macrophages. So most of the time in granulomatous inflammation, they will fuse to form these multinucleated giant cells. So once there is a formation of multinucleated giant cells, so we call it as Langhans type of giant cell in case of tuberculosis. So monocytes are the precursor cell for all these epithelioid cell granulomas. Modified basophils are called as mast cells, so that will be seen in the tissues. Eosinophils, we call them as eosinophils both in peripheral circulation as well as even in the tissues. CD4 T lymphocytes, of course they are the most important helper T lymphocytes. Next question again on the granulomatous inflammation here. Epithelioid granuloma may be seen in all the following conditions except sarcoidosis, tuberculosis, Crohn's disease, mycoplasma. So which is not the granulomatous condition? The answer is, my friends, go back to again granulomatous inflammation. I have made a mnemonic M, B, B, S, C, L, L. Right? So there are so many granulomatous inflammation. M, Mycobacterium tuberculosis. B, berylliosis. One more B, brucellosis. Then S, sarcoidosis. C, cat scratch disease. Leprosy, that is tubercular leprosy. Lymphogranuloma venereum. So there are so many conditions. Isle granulomas, foreign body granulomas, so many conditions which will cause the granulomatous inflammation. It is not only the tuberculosis. So you will see non-caseating granulomas in case of sarcoidosis. Tuberculosis is of course the prototypical of these granulomatous inflammation. You will also see the formation of the granulomas. Crohn's disease, that's the important one. Again, you have to differentiate it from the ulcerative colitis mainly by seeing this finding of mucin secreting granulomas, mucin granulomas. We call it as mucinous granulomas or mucin granulomas. They are very commonly seen in the epithelium. So mucin granulomas are again classical finding in the biopsy cases of the Crohn's disease. Yes, it is the mycoplasma is the answer. So the answer is mycoplasma. You will not see the mycoplasmal infection will not causes the granuloma formation. So variety of fungal infections also causes the granulomatous inflammation. So remember what are all the granulomatous inflammatory conditions. Wherever you see those granulomas, so you make a list, make a mnemonic and try to remember all the granulomatous inflammatory conditions. Next question, not a characteristic of tubercular granuloma. Options: central area of caseous necrosis, epithelioid cells, Langhans type of multinucleated giant cell, peripheral PMNS, that is polymorphonuclear cells. So which is not seen in the tubercular granuloma? Yes. If you see the classical granulomas of the tuberculosis, always, most of the time there will be a central area of caseous necrosis. So that is almost classically seen in the tubercular granulomas. So these granulomas, central areas of caseous necrosis, that is surrounded by epithelioid cell granulomas. So that is mainly consisting of epithelioid cell macrophages. There can be one formation of the Langhans type of giant cells. That is surrounded by cuffing of the third zone. Central area of caseous necrosis, first zone. Second zone is the epithelioid cell macrophages. Third zone is the lymphocyte and plasma cell cuffing. Lymphocyte and a plasma cell cuffing, because it is a chronic inflammatory process. Remember, granuloma formation is the chronic inflammatory process. It is not acute. So there is no role for the neutrophils as such. So the answer should be peripheral PMNs. So that is polymorphonuclear cells, nothing but neutrophils. So you will not usually see the neutrophils in the tubercular granulomas. So classic granulomas will show cuffing by the lymphocytes and plasma cells. That is surrounded by, if the lesion heals, then you will see the fibroblast layer, the layer of the fibroblast, and finally it undergoes dystrophic calcification. Totally the tubercular mass can be get calcified. So you will not see usually the neutrophils unless these conditions are get inflamed later on. The most essential criteria for tubercular granuloma is, remember that tuberculosis is the very common and favorite test question for the exams. Option A, central area of caseous necrosis, non-caseating granulomas, Langerhans type of multinucleated giant cell. Fourth, positive for AFB, acid fast base A. So what is the most important criteria? For which criteria you will give more importance? Is it a necrosis, caseous necrosis you will give more importance? Non-caseating granuloma. No, most of the time we will see caseating granulomas in tuberculosis. Where you see non-caseating granulomas, it is in the sarcoidosis where you see the non-caseating granulomas. Third, Langerhans type of multinucleated giant cell. It is actually a foreign body type of giant cell, can be seen in variety of other conditions also. Yes, the answer is AFB has to be seen to call it as a tuberculosis. So you have to do the Jeal-Nelson stain to look for these acid fast bacilli. So unless we see the AFB, we will not call it as tuberculosis in origin. If the AFB is seen, then we definitely call it as tubercular granulomas. If AFB is not seen, then we just label it the cases as granulomatous inflammatory condition. So it is left to the clinician again whether it is a tuberculosis or some other granulomatous condition. So most of the time AFB is the one which will decide. Most of the time that is the most important stain we will do at the clinical setup. So even if it comes negative, then we have to redo it once again. So sometimes it's a technique. If the technique is done properly, definitely if it is case of positive tuberculosis, it will come positive. So you have to confirm. That's why the immunofluorescence techniques have come into existence. Nowadays we have Aramin stain and Rhodamin stain where tubercle bacilli will be demonstrated. So Jeal-Nelson stain is actually a manpower mediated. So it's if you do the technique correctly, it will come positive if it is a case of tuberculosis. If you don't properly heat the solution, carbonyl fission solution, what we heat, if it should be heated till the fumes comes. So if you don't heat properly or if you less heat or overheat, then there is a chance of error. So the AFB cannot be seen properly. So there is a chance of making the diagnosis a little tough. So Aramin, Rhodamin are the immunofluorescent dyes for the demonstration of the tuberculosis. But the most confirmatory nowadays is little bit expensive. That is PCR, that is polymerase chain reaction. So that can be recommended if the patient is able to afford that particular investigation and if you are strongly suspecting it as a tuberculosis. But most of the time it is all criteria you have to take into account, then only you have to look what investigation you want to order. Sometimes acid fast bacilli can be even culture can be done using the Lowenz-Jensen media. So LJ media will be used commonly, but it takes a little bit longer time. And nowadays we have even the techniques where rapid growth is possible. So advanced techniques are coming up. So remember, the option correct choice is the positive for AFB. You have to see the causative agent, that is acid fast bacilli. Yes, we have a question here, the last question of this session. Which of the following is most essential for confirmation of tuberculosis again? So the choices are Mount X test positivity, chest X-ray showing cavitation, AFB positivity, clinical presence of cough and sputum, significant weight loss and loss of appetite. So as I told, until I see the AFB positivity, I cannot report it as a case as a tuberculosis. Mount X test positivity, my friends, Mount X test is not to diagnose the tuberculosis, it is one of the screening tests. So whenever you do the Mount X test, if it comes to 6 to 9 millimeters size in duration, then the patient it indicates that patient has received the vaccine or patient has immunity to the tubercle bacilli. If there is no reaction at all, then it indicates that patient is immunosuppressed. Such cases you have to evaluate for immunosuppressive status like HIV or any other immunosuppressed state. So if the induration is more than 1 millimeter, then you have to think that he could be a case of hyper-responsiveness. So hypersensitivity reaction might have taken place. So those cases has to be again evaluated carefully. So Montex test usually done in the pediatric population to know the susceptibility as such and to know the familial contacts, the family contact people. So it is not actually the confirmation of the tuberculosis. Chest X-ray showing cavitation, yes, cavity will be formed in the tuberculosis, but cavity can be formed for many other reasons, not only tuberculosis. Even some of the tumors, they can cause cavitatory lesions. So cavity formation is not 100% sure that it is a case of tuberculosis only. There can be some more causes. Clinical presence of cough and sputum. You will see hundreds of lesions, conditions, clinical conditions where you patient will present with a cough and sputum, and you cannot just by having cough and sputum, you cannot label the patient is having tuberculosis. So you have to rule out all the conditions which will cause us the particular clinical scenario. And significant weight loss and loss of appetite. Yes, the weight loss is important for tuberculosis, but any weight loss is not tuberculosis. All the weight loss are not tuberculosis. So that you have to keep in mind. So clinical criteria they are useful, but they are not the confirmatory. So with that, we'll end up a session here. We'll continue in the next session. Thank you.